Pleasure. Nice to have you here.
Well,
I'd like to introduce Professor William Devine from Arizona. Good to have you here. Please, first of all, tell us where you work now and what is the main work for the last weeks.
well, thank you very much for being here. It's a pleasure at the conference. I am a full professor at Midwestern University's campus in Phoenix, Arizona. Actually, it's a suburb called Glendale, Arizona. And I'm a professor of osteopathic manipulative medicine there. I teach all 4 years of the medical students. And also, I'm in charge of teaching the osteopathic medical component of all of the residents in the state of Arizona. So I teach osteopathic concepts to residents in internal medicine, emergency medicine, family medicine, even dermatology, general surgery, and orthopedic surgery. Those are the primary residents that I teach. And it's a little busy.
Yeah, very busy work. Yesterday, you told us something about reflexes, one of your favorite contents when you work, Chapman reflexes, the treatment of strain and counter strain. You told us your own connection, your own relationship to these reflexes in relationship to your heart. In history, you needed 2 stents. Please, can you tell us this story again? It was marvelous to hear yesterday.
Well, it was interesting. As a professor in teaching different topics, one of them is differential diagnosis with typical and atypical chest pain, whether it's cardiac or non-cardiac. Is it from, for example, chest pain from a collapsed lung is part of the differential diagnosis. And I was at a committee meeting. Matter of fact, we had a student that was failing. And it was early in the morning, and my wife, who is a clinical pathologist, head of the Department of Pathology, she's an osteopathic physician also, was there. And some of my patients, who were professors, were there. And I developed left mid-thoracic pain that was quite localized. And part of the concepts of differential diagnosis, whether it's cardiac or not, is it relieved by positioning? Well, counterstrain, since I teach counterstrain also, with that particular reflex spot, I went into the position of counterstrain. It did not turn off. So then I checked the next system of diagnosis known as Chapman's reflexes, and they're very positive. And I had no shortness of breath, no diaphoresis, no pain down the arm at that time.
So it was not classical for
it was
heart
not
disease,
classical. No? I was what's called in the state of pre-infarction.
Yeah.
Nevertheless, I looked at my watch. The meeting was over in a few minutes. I excused myself and sat outside the meeting room waiting for my wife. And one of my patients, who's head of the Department of Pathology, of Pharmacology, who had a bad back, and my wife saw me, and I said, well, I need to go to the emergency room. And so my patient with the bad back helped me to the car while my wife drove the car to the front door of the university, and we drove to the emergency room. Yeah. And I told him I was having a heart attack, and the rest is history. But the actual infarction probably did not occur until about 1 or 2 minutes before we hit the emergency room. In other words, at my age, I had no collateral coronary artery circulation. My chance of dying of acute cardiac arrest was very, very big. So I had 2 stents installed within 20 minutes, and I'm here today probably because of Chapman's reflexes and knowledge of how to differential diagnose chest pain, because I'm pretty active from a musculoskeletal problem.
Okay.
That's the story.
Okay, that's a marvelous one. Thank you. Another aspect of your work is the relationship between soma dysfunction and the viscera, the organs,
Yes.
and also the other way around. When you have got an ill viscera,
Yes.
an ill organ, you will see different somatic dysfunctions in relationship to the organ. Please tell us something about the relationship.
Well, it's a major advantage being an osteopathic physician in that my professor was Fred Mitchell Jr. And my father was an osteopathic physician. He was a surgeon. He was a urologist. He graduated from Kirksville in 1933. And I was taught viscerosomatic and somatic reflex presentations in the clinical diagnosis of patients. I was surprised. I was drafted as a family physician for our Vietnam War, and as an Air Force doctor, I was exposed to my allopathic colleagues, and they had no idea how to diagnose a patient without laboratory assist or imaging assist. And not only did I have hands that could detect the viscerosomatic patterns, which gave me rapid diagnosis and actually life-saving diagnosis, but also a theory as how to treat. And so having this knowledge allowed me to triage acutely ill patients. Where I was stationed, we had a lot of retired military too, and so it came in handy for pancreatitis, which was one of my in the first week in practice at the base where I was, not diagnosed ever. So the Chapman reflex that my father used as a urologist, probably started using them in the 1950s, really came in handy, of course, what Fred Mitchell Jr. taught me. So it probably saved a few lives since I'm in acute care medicine.
We are looking for, especially in this, or maybe in this kind of Congress here, it is a very nice platform to talk with someone like you, or to talk to others. We are looking in osteopathy for also for evidence. What do you think in future we should do, where we can find maybe more evidence to have more standing in osteopathy?
As osteopathic physicians try to get more recognition on the continent here in Europe, evidence base is really important. Certainly in America, the MD and the DO physicians practice in the same hospital. There is no discrimination anymore because of the evidence we've achieved, but also our accomplishments that we have. But here in Europe, I understand it's not recognized. The level of scientific evidence that we've achieved so far. So the evidence that we have in, for example, lymphatic circulation, and the evidence that the pneumonia studies that have been done, not just the low back studies that have been published in the New England Journal of Medicine and so many prominent journals, that may be enough. I think that certainly the evidence based on research that's going on, I have colleagues, osteopathic colleagues in Italy. They have some very creative research activities on pediatric patients, which I think will be important to the Italian government in recognizing the Italian DO. Understand there always is politics in every country. There are some groups that don't want other groups to exist. Evidence in performance is what it is. So what they're going to look at is the bottom line. Is this saving the government money? I don't see that the government will pay for feel-good.
It's a problem.
If an osteopathic physician is just treating pain in some systems, the government may not appreciate that. For example, in Phoenix, Arizona, it's beautiful in the winter. Today it's probably about 27 degrees centigrade again.
Yesterday you've shown us snow in Arizona also.
That happens. But we have a lot of Canadian, what we call snowbirds.
Yeah.
And they come down from Canada and they winter in Phoenix, where it's beautiful. And I had one gentleman come in from Canada who was a wheat farmer from Saskatchewan province. And he came in his shorts, and I looked at his knees. He was a new patient. This was in my osteopathic family practice. And I said, well, obviously you're here because of your knee. He said, yes, it's killing me and it's swollen. And I said, we have a lot of arthritis there. He said, well, I fell in the shopping center. I tripped. But I need a refill on my codeine. And he was on Tylenol number 4, which is the highest strength codeine tablet with acetaminophen. In my lifetime of practice, I've never written for that. He said, yes, they give me several hundred of them at a time that I've been taking. I said, why didn't they replace that knee? And they said, well, in Canada, they say that oak trees get old and they die. In other words, they had selected him out from a knee replacement because he was 74 years old. His body build's about the same as yours that you have. He really is a healthy man. And I said, well, welcome to America. You're going to learn all about healthcare. He had a new knee within 2 days, and the shopping mall paid for part of it. His negligence to him slipping, but that's the legal system.
Okay. Did he spoke about the cost of a total knee replacement?
Yeah, he said that he was too old to have it done.
Yeah,
but his health was excellent.
How many cost will?
Oh, so probably 1,000 Tylenol number 3 generic, or not number 4, excuse me, generic, would probably be maybe $30, maybe $40.
Yeah.
Very cheap generic. Of course, the surgery, quite a few thousand, probably 10,000.
Yeah, it is unhuman what you're talking about.
He spent 6 weeks, as I recall, in drug withdrawal from the codeine.
Okay. And you could have helped him.
He had to have the knee replaced. But if I have patients with a minor sprain of arthritic knee, I can take down the swelling and inflammation. And let's say they have a serious heart condition or lung condition, or let's say they're in renal failure and they're a bad risk for the knee surgery. I can see them about every 2 to 4 weeks and help them quite a bit. Not 2 to 3 times a week, but like some of our other manual therapists do. But I can actually teach them how to treat their knee themselves using counterstrain manipulation and indirect myofascial release on the knee, on that particular joint. Also, I teach my orthopedic surgeon residents how to treat the knee after a knee replacement surgery, which is...
And very early.
which is really important because in Arizona we have so many retired people. We have a lot of people that have inflamed knees after knee replacement. And this gentleman I did treat, of course, and help him heal faster because of the treatment.
Definitely. Yeah.
And he's very happy and healthy Canadian that is still around.
At what time do you start after the operation, after hip or knee replacement?
Well, I treat before the surgery to make sure all systems are stabilized because they have to survive the anesthesia.
Yeah.
And it's a fairly light anesthesia, but still I try to treat them as much as possible to maximize the circulation necessary for the surgery. I did 27 years of family practice. I did first assist in all my neurosurgeries, all my open hearts, all my knee replacements, all my hip. I'm not doing that now at the university, but knowing all this before and after surgeries over the years, I've learned to treat the post-surgical knee by actually using indirect myofascial releases and literally emptying out the inflammation and promoting healing. Not just local to the knee, but you have to treat the thoracic outlet first, then rebalance the diaphragm, and then the hip. And there's a lot of compensatory problems with a bad knee. So you have iliopsoas muscle problem. You have other types of rebalancing that should be done prior, but it'll keep coming back as long as they have a bad knee. That's adaptation. But you need to treat it as best you can before the surgery. It's not actually that complicated.
To let the fluids flow before and after operation.
Yeah, the function.
This is your philosophy.
Yeah. Also, I have them trained how to use a cane, crutches, or a walker, depending on the surgery, whether it's a hip replacement or knee replacement.
We are nearly to the end. Please give our students, all to us, a short sentence, maybe a take-home message concerning the relationship between strain-counter-strain, the Chapman reflexes, the connection between the viscera and the somatic, and the somatic and the viscera relationship. Or question is, where do we have to look when we examine a body? We should often more look for the skin and for the superior tissues to get more information to the inferior organs. Please give us a short take-home message concerning
this. Well, the take-home is, if you really think about philosophy, probably osteopathy started with Hippocrates, looking at the whole body, and also listening to the patient. You mentioned skin. Hippocrates said a man's health is mirrored by the skin, and he was very right. He knew physiology. So as a student, I'd suggest that a student learn the autonomic nervous system, understand that simple treatments involving the vagus nerve, which at the foramen magnum to the first and second cervical, and then the thoracic outlet, and then in the diaphragm area, those are all vagus, and also vagus goes into the viscera. So knowing those treatments that may not stimulate the vagus, which is parasympathetic system, but to rebalance it. And as far as the sympathetic division, that gives the Chapman reflex. If there's a dysfunction of the sympathetic outflow out of an organ that's injured, like a heart, there'll be a positive Chapman reflex.
In your case.
Yeah, the anterior reflex is more identifiable, but the therapeutic reflex for heart, for example, is between the third and fourth thoracic vertebra. Understand that the posterior reflex has to be treated. Understand that in Chapman reflex, that's the last thing that is done. You do the best you can by identifying the key lesion if possible, and treat those areas first. And then see if the reflexes are still there, and then treat them. But Chapman always did it last. I suspect he did what's called a general osteopathic treatment, which actually was an examination and treatment prior. But also prior to that, as a clinician, taking that history is really important, because once again, the physicians before us said, listen to the patient. And so much of the time now we have a computer and we're typing in information in the computer. So that link, you have to learn to listen to the patient. When they say that their shoulder hurts, ask them, show me with your hand where it hurts.
Yeah.
And that sweeping motion means it's probably a myofascial origin, as opposed to it hurts here, and they'll point at the acromioclavicular joint, or here, the long head of the biceps tendon. So if you have your notes, doing your notes and not paying attention when you ask a question, that's an important time for the patient. They really want to tell you where it hurts and show you. And if your nose is in your notes, you'll never achieve that relationship, but more important, the diagnosis.
Okay.
That's a long answer.
Okay, thank you for the warm words, for the I'm very excited to hear your experiences. Mm-hmm. Have a good time in Berlin anymore.
Yeah,
thank you for the interview.
All right. Thank you.
Thank you, Professor Devine.